In medical school, we had an emphasis in the early stages of training on biochemistry and pharmacology and other kinds of medical disciplines. In spine surgery and orthopedics, we really talk a lot about biomechanics, which is a little bit different way of thinking about things. So I wanted to discuss with you what I consider to be the ABCs of spinal biomechanics. The A stands for alignment. Everybody's built a little bit differently, but we all have a certain alignment that hopefully puts our head centered over our pelvis and feet. In the spine, think about the first vertebrae as actually being the pelvis and the sacrum, and then from there the spine is built level by level all the way up into the head, with lordosis in the lumbar spine, which is a curve one way, thoracic kyphosis, and then cervical lordosis again. All of us are built a little bit differently. Some people have a relatively flat lower back and may be predisposed to disc problems. Others have a relatively curvy lower back or high lordosis, and they may be predisposed to facet joint issues and pars issues. The second, B, is balance. Alignment is a part of spinal balance. Balance really takes into consideration external forces, primarily gravity, and our musculoskeletal response, which starts with the nerves that sense our movement and position in space. If I lean forward, I am now maybe out of balance, and the spine has to respond by contracting the muscles to hold me from falling over or adjust in some other way. C is compensation. If a pathologic state occurs that changes the alignment in order to maintain ergonomic balance, the spine and the musculoskeletal system needs to compensate in some other way, which is really confusing to understand. So let me explain a couple of examples. Say, for example, I have a leg length discrepancy. One leg is longer than another. Or maybe you've been walking in a walking boot for a while and one leg is longer than another. There has to be a compensation for that. The spine has to adjust to make up for that difference. Another example of compensation is with a disc that degenerates. When a disc degenerates, lordosis, or that curve in the lower back, is lost. And in order to compensate, other areas have to lean back. So the adjacent level might shift the alignment backwards into an extended state. Also, you could have compensation occur at the hips or at the knees. We could extend our hips or bend our knees to compensate for loss of disc height. So what does this mean for you from a practical perspective? If you have a problem in the spine, for example, a degenerated disc, that underlying issue should be addressed and treated and managed appropriately. But you should remember that other areas of your spine, your hips and your knees and even your ankles are compensating potentially for that underlying issue. So don't forget the rest of the musculoskeletal system. Secondly, let's say, for example, that we treated an underlying problem in the back. Say we treated a degenerative disc with a discectomy, or maybe one that had progressed more and we did a spinal fusion. We've treated maybe the primary issue. There are still secondary issues that exist, and the physical therapist after surgery may work with you to help with those areas. Patients that may have pain after surgery could have pain that's residual from areas that have been compensating and have been stressed. Biomechanics is really confusing, and I get confused by it sometimes, and I think it's a different way of thinking. And I think if we want to be good at root cause analysis and management of spinal pathology and musculoskeletal pathology in general, we need to be thinking a little bit more biomechanically.